Hello and welcome to DrugsPlus. Whether you're here for exam revision or just general interest, I hope you find this video useful. If you do, please give it a thumbs up and subscribe to support this channel so that I'm able to continue creating this content. In this video, I'm going to discuss anti-platelet therapies for the prevention of arterial thrombosis. For a more detailed introduction to thrombosis, you can see my thrombosis video, which I'll provide the link for below. I'm going to start by introducing the process of thrombus formation in the arterial system. This is a platelet. When a blood vessel is damaged, collagen and von Willebrand factor from the extracellular matrix are exposed to the blood. Platelet adhesion molecules GPV1, GP1b and integrins bind to these proteins and begin the process of platelet activation. This causes the platelet to release serotonin and thromboxane A2, both of which mediate vasoconstriction. This pushes activated platelets closer together to promote aggregation. Platelets are also activated by thrombin, which you'll see more about in the coagulation cascade next. This thrombin acts on the protease-activated receptors, or PARs, causing the release of intracellular calcium stores, which activates cyclooxygenase 1, which subsequently generates further thromboxane A2. Platelet activation also induces the release of ADP from dense granules, which goes on to activate nearby platelets via P2Y receptors, stimulating the expression of GPIIb3A receptors, or fibrinogen receptors. This allows fibrinogen molecules to connect to adjacent platelets, causing aggregation. As platelets are activated by a number of different pathways, no drug will be able to mediate total prevention of aggregation, although many are relatively effective. The first antiplatelet therapy I'm going to discuss is aspirin. As discussed, COX-1 is responsible for generating thromboxane A2, which goes on to mediate vasoconstriction, which facilitates platelet aggregation. However, COX-1 also generates prostacyclin, which does the opposite, mediating vasodilatation. So when aspirin inhibits COX-1 via covalent modification, there shouldn't be an overall net effect with regards to blood vessel lumen diameter. However, the endothelium constitutively expresses COX-2, which only generates prostacyclin, so this predominates and vasoconstriction is prevented. The next antiplatelet therapy is phosphodiesterase or PDE inhibitors. PDE is an enzyme that breaks down cyclic AMP. Therefore, when a PDE inhibitor is used, for example cilostazol, cyclic AMP concentration increases and actually promotes the release of ADP, which goes on to activate adjacent platelets. Therefore, PDE inhibitors decrease the rate at which platelets are activated, thus preventing the formation of a thrombus. Next is ADP receptor antagonists. As you might expect, these drugs block platelet ADP receptors, preventing ADP-mediated activation. Older drugs in this class, such as clopidogrel, are prodrugs which produce active metabolites which antagonize the ADP receptors, whereas newer drugs, such as ticagrelor, antagonize the receptors directly. This antagonism decreases the rate at which platelets become activated, thus preventing the formation of a thrombus. Next is GP2B3A antagonists. Usually, fibrinogen binds to these molecules, which allows them to bind to other platelets. However, these drugs, including eptivipotide, antagonize fibrinogen receptors, preventing fibrinogen from binding, thus preventing the formation of a thrombus. One issue with these drugs, however, is that they are so potent at preventing fibrin cross-linking that they can induce thrombocytopenia, low platelet levels. This is a perfect case of an imbalanced hemostasis. The final class of antiplatelet drug is the PAR1 antagonists. These prevent thrombin from binding to platelet PAR1 receptors, meaning they cannot evoke COX-1 activation and therefore vasoconstriction. These are an emerging class of drug and are not yet approved for use. However, phase 3 clinicals are ongoing for vorapaxar and are promising, although they are showing a risk of hemorrhage. Thank you for watching this video. If you found it useful, please give it a thumbs up and subscribe to support this channel so I'm able to keep creating this content. I'll be back soon with more pharmacology videos.